Hello, people. So, what is the difference between a pneumonia we classify as typical and an atypical pneumonia? So, on the left side, I will try to explain the typical situation. So, a typical pneumonia pattern. Basically, when we talk about typical pneumonia, we mean that these pneumonias present in a typical clinical pattern, and basically it is easier for us to distinguish that this is a pneumonia, an infection of the lung parenchyma. In these typical pneumonias, we have an acute onset, a sudden onset. In a few days, all the symptoms become clear. We have symptoms like fever that is very common, and this is a fever that is above 38 Celsius. We have chills, fatigue, a productive cough with sputum development, and these patients have most of the time good physical findings. So auscultatory, we will hear crackles or a diminished lung sound. Percutory, we will find a flat or dull sound. And laboratory findings will also be good. We will see white blood cells rising. And then when we do an X-ray, we will find most of the time localized and clearly visible consolidation. So why is this all happening and how in this typical pneumonia? So on this left side, if we analyze the lung tissue that is affected in pneumonias, and if we, for example, do an X-ray, we will most of the time see a unilateral localized consolidation as it is here. So this is the part of the lung tissue that is inflamed. And if we zoom into this, and if this represents an alveoli and this a bronchiole, so the inflammation is happening, the exudate is in these alveoli. Obviously, this is showing up on X-rays as a localized consolidation. And our findings that we find in the physical examination, auscultator, we can hear a diminished lung sounds or crackles here. We can percutory analyze that here. We can localize that there is a flat or dull sound in the right part of the lower right lung. Also, these patients have a productive cough. Most of the time, the cough is actually productive. So, productive. So, most of these patients produce a sputum, and this sputum is most of the time purulent. Sputum. Why is this happening? Because the alveoli, the process, the exudate is in the alveoli. Our body wants to eliminate it, and we are starting to cough. The reflex is being activated, and we are starting to eliminate it by cough, and we cough out this sputum. So on a macroscopic and microscopic level, these are the main changes in this type of pneumonia or typical pneumonia. So an exudate in the alveoli, a localized pattern of inflammation in the lung, and then a localized consolidation in an X-ray, and then all those typical acute findings and all those typical laboratory findings and typical physical exam findings you would expect. On the other hand, we have the atypical situation. So in these atypical pneumonias, things are different. So analyzing these pneumonias have a slow onset. So slow onset, or better to say, they are subacute. And everything in these pneumonias is a little bit sub, I would say it like that. So these people don't have a high fever. They are subfebrile. Also, the cough is dry. So they have a dry cough and they rarely produce sputum. Also, they don't have many physical. In the physical exam, we don't find much, and it is really hard to distinguish any of those classical, typical findings. Also, on laboratory testing, these people do not have that high elevated white blood cell count, so it's only a slightly elevated, or even uncommon. It is uncommon for the white blood cell count to be elevated. They will have fever and cough, but as I said, the cough will be dry, in contrast to typical pneumonia, where it is most of the time productive. And they will have fever, but it is also not high fever, subfebrile. With those symptoms, they mostly have symptoms that are actually mimicking symptoms of viral infections, like headaches, myalgias, or they will have accompanying symptoms like accompanying infection patterns like pharyngitis or rhinitis. If you do an X-ray, you will, in contrast to those to the lack of physical exam findings, see that there is most of the time a bilateral diffuse pattern of inflammation. So you will see on X-ray that there is something happening in the lung. And if we go down to this, if we take this route, histological route, we will see that the inflammation is actually not in the alveoli, but in the interstitium. And in interstitial inflammation pattern. And that is why these patients, they have not much to cough up. And that is why the cough is mostly dry. So, why is this happening? Why do we have these two patterns develop? It is basically the etiology. So, the etiology of these acute or a sudden onset pneumonias, typical pneumonias, is basically the bacterial, and these pathogens are extracellular pathogens. The etiology in atypical pneumonias is an etiology. Basically, these pathogens can be bacterial or viral. Viral pathogens are intracellular, but also some special bacteria, atypical bacteria, that have the possibility to survive in our immune cells. So intracellular or paracellular pathogens. And this etiology predisposes these different clinical presentations. So if we take a look at typical pneumonias, so this is a macrophage in our lung, and these are extracellular pathogens. Let's say these are little bacteria. So they are extracellular pathogens. These bacteria in these typical pneumonias are, for example, pneumococcus or Streptococcus pneumoniae, which is the most common bacteria causing community-acquired pneumonias. So one of them. Another possibility is Staph aureus. Then another possibility is Klebsiella. then, for example, Pseudomonas, infection, and so on. So we see that many gram-positive and gram-negative extracellular pathogens, bacterial pathogens, but they are extracellular. They are actually multiplying outside the cells, and the macrophage is fighting them by internalizing them and eliminating them by phagocytosis and fusing with lysosomes and then destroying them. So these extracellular pathogens cause most of the time these typical pneumonias, where we have all these classical findings. On the other hand, when we look at this atypical pattern, the pathogens are some interesting bacteria. One of them is Legionella. This bacteria is interesting. Legionella pneumophila is actually a bacteria that has the potential, when it is being phagocytosed by a macrophage, so if this is a Legionella and the macrophage takes it up by phagocytosis, this bacteria has the potential to resist phagocytosis inside the macrophage, and it is now multiplying inside the cytoplasm of macrophages. It can also multiply in other cells. Something similar happens with, for example, mycoplasma. Mycoplasma don't have this characteristic peptidoglycan cell wall of the bacteria, and they look similar like the cell wall of our cells. And they can live very near to our cells and use them and even be internalized and multiply inside the cells. So they are some kind of paracellular pathogens. Then we have obvious intracellular pathogens like, for example, viruses. Let's say influenza, or the newest corona. And many of these pathogens are intracellular, and they make for this atypical clinical picture that we see in these atypical pneumonias. So in the end, what is this clinical difference? I will stress it one more time. So the typical pneumonias have an acute sudden onset. They have a productive cough, coughing off sputum, and also the irritation can irritate the pleura. So if the pleura is irritated, this can lead to chest pain. So we can have it is called pleuritic chest pain. Pleuritic chest pain. Then we can also have fatigue, and it is common that they also have a higher temperature. It is common to have a higher white blood cell count, and physical exam findings, we will have many of those. And on X-ray, we will see this localized pattern, mostly unilateral. In contrast to the atypical pneumonias, the cough will be dry. Chest pain is uncommon. Also, these patients will have fatigue. The temperature will be subfebrile most of the time. The white blood cell count will not be elevated, or it will be slightly elevated. And also, white blood cells that are elevated here are neutrophils. because neutrophils fight these extracellular pathogens. But white cells that will be, if they are elevated, we have an elevation in lymphocytes. So because lymphocytes fight intracellular pathogens. And then physical examination, we will not have many physical examination findings. On X-ray, we will see most of the time diffuse pattern and a pattern that is bilateral. So we see that typical pneumonias can be diagnosed maybe a little easier by the untrained eye, but the atypical pneumonias we need to search more, and they have this atypical pattern and these atypical findings. I will only say that some of these findings correlate with this virus and intracellular etiology, and some of them are also headache, myalgia, and the accompanying possibility to be accompanied by symptoms of pharyngitis and, for example, rhinitis. So this is a simple overview of the difference between a typical and an atypical pneumonia clinical picture. Thank you.